Our next presenter is Lori Kingdon. I met Lori probably, when did I meet you, Lori? 5, 6 years ago? Yeah, 5, 6 years ago. Yeah, and we've had some amazing talks, and she's helped me understand a lot of stuff that I didn't understand in the beginning with everything of acromegaly, but she helped me to understand on the nurses' side of understanding acromegaly, and I really thought it was important that people kind of understood the journey of what the RNs can do for us too, besides our endocrinologist. So Lori Kingdon is a case manager for Dr. Shireen Isaac at the University Health Network, Toronto General Hospital, and Princess Margaret Hospital in Toronto. Lori has worked in the area of endocrinology for
38 years now.
38 years and
19 in oncology.
19 in endocrinology. Lori, I can tell you without a doubt, has dedicated her life to her job. And that is something that we see, but we really don't see a lot of. She's helped those with acromegaly, growth hormone deficiencies, HIV/AIDS, wasting of growth hormones deficiency, by making sure everyone receives the best quality of care. Lori has run multiple clinical trials with coordinators and taking the massive knowledge she has gained to promote more awareness at national, international conferences around the world. Lori is a member of the College of Nurses of Ontario, Nurses Association, and founding member of the Canadian Nurse Acromegaly Association. Please welcome Lori.
Good morning. So Mark had mentioned about our acromegaly support group. So I've had 6 meetings. So hopefully we can get it passed off to an actual patient, because we tried numerous times. And every time I'd get a patient lined up to take over the meeting, things would happen. So hopefully we can get this going.
I just emailed Mark to say I'm here.
Perfect, Cynthia.
I just got an email from her saying she's in.
Good. Okay. Oops, that didn't quite go. Anyway, so to those new patients, there's a few of you here today. I think there's 3 brand new ones. And I just diagnosed another new one on Friday morning. And to those of you who are probably marking your 30th or more year, welcome. All of our patients should have the following testing performed, and if possible, I'll go through. I'm going to give you a little history lesson on, as I said, I've been working in endocrinology since 1983, so a lot of things have changed for the better, thank goodness. So one of the first things I did was, because back then I had numerous rooms to do endocrine testing in. So I'd do a buddy system. So I'd bring an experienced patient in for their testing and a brand new patient in. Because all the world that we can do, all the information that Dr. Izat and I can give you, sometimes it doesn't always resonate with the patients, but being able to talk to someone else with your own disease. Over the course of our time, we've probably had 600 acromegalics in our practice. Right now, actively, we have 271. So again, talking to another patient, sometimes you're going to ask them questions that either you're too uncomfortable to ask either Dr. Izat or myself, or there's just general things. Like, I haven't had pituitary surgery. I can tell you all the steps, all the tests that you're going to need, but somebody who's actually had the pituitary surgery might be able to answer more questions. So the first test we're going to do is an oral glucose tolerance test. So as I said, I'm going to give you a little background history on that later on. So it'll be an oral glucose tolerance test, then there's baseline blood work. So I know you call me Dracula because sometimes I've drawn a lot of tubes. 2 of the patients last year, their baseline testing was 29 tubes. Now, for one of my tests, an insulin tolerance test, it's 28 tubes for itself. So for the baseline of 29 tubes, that's a lot of hormones. So you can see some of the hormones, and I actually have little teaching aids I brought for you. So Rada, if you could come up for me. Rada's going to help me demonstrate. So Mark's already shown you Shireen's perfect model that just sits on the counter. Mine gets pulled out every time I'm doing testing, so mine's falling apart.
Yes, it's falling apart, but it's still.
Okay, so this is your normal pituitary gland.
Stays there, yeah, it's there.
Okay, with the mic. Is this on? Can you hear me now? No. It's lit up now. Okay. So this is a normal pituitary gland. So your anterior hormones is in the red. The brown section is the posterior, and this is your optic chiasm. And on either side is your carotid arteries and your cranial nerves. So that's a normal pituitary. A microadenoma is this white thing. So it's just starting to push up the optic nerves, and it's just starting to compress the pituitary gland. And for most of my patients, because they've usually anywhere between 10 to 20 years of diagnosis, this is what most acromegalic patients' tumors look like, this beige section. So it's compressed the pituitary gland. You've got very little hormone function. So if you're a male, you're probably hypogonadal, so you have no testosterone levels. If you're female, you probably have no menstrual periods. You're missing your thyroid hormones. That's usually the first hormone that we replace. And then it could also be surrounding the carotid arteries or the cranial nerves. So as in Mark's case, he mentioned that he still has to keep having surgeries done and that there's always residual left. We can only take out this portion. We can't touch what's around the carotid arteries because we don't want to cause a stroke, and we don't want to cause blindness if it's surrounding the optic nerves. Okay, so that's our pituitary. And I can show you this later. Okay, there. Then you're going to have MRIs of your sella. You're going to have visual field testing because, as I said, your vision could be impaired either the left or right side if it's surrounding or pressing on one of those nerves. Bone mineral density test to measure your bone loss. Colonoscopies to check for colon polyps, and we're looking for cancer. And dentist. Now I've got another model for that. 2 models. Here's one. So one is a normal patient, and this is an acromegalic patient's jaw. Yeah. Okay, so the normal one actually is mine because I had to go and get, after I had root canal surgery and it failed, I had to go and get a night guard made, and the other one is my acromegalic patient. So his jaw, you can see in his jaw, he's actually losing his teeth. His jaw is elongated, he's losing his teeth, he's got severe jaw pain, a lot of headaches, and then when we brought him in for testing, not only is you could obviously see that he was acromegalic, but we also determined when I did his CBC, I had worked in hematology for 14 years. And I ran over to Dr. Iza and I said, there's definitely problems with this patient's white blood cell count. Turns out, newly diagnosed leukemia, thanks to me. So as far as I know, he's our only leukemia patient. So he's been treated both for his acromegalic disease and his leukemia. So when I went to see my dentist, I guess I gotta advance this. When I went to see my dentist, I said, do you have any acromegalics in your program? And he said, well, what's acromegalic disease? Like, what is that? So I started explaining to him, and he said, I said the elongation of the jaw, the gaps between the teeth, headaches. Some people have a lot of nerve compression damage, but sort of the light bulb went on. And he said, no, I don't, but I could just see the way he looked at me, and he said, so I said, my dentist is, we live in the heart of the gay community, so we have a lot of gay patients. So I said, do you have a lot of people who inject illegally growth hormone? And he said, yes. I said, do you have, are they getting it by mail order either from the States or China or elsewhere? And he said, yes. I said, are you noticing problems with their alignment and their jaws and their teeth? They're having more cavities and more spaces and their teeth are falling out. He said, yes. I said, these people are becoming acromegalic. If you have Dr. Iza, you'll notice that he always has his handy-duty stethoscope. So he's checking your thyroid gland. None of these is listening to your heart because we're looking for cardiac irregularities. So we're looking, he's checking your heart, and he's palpating your heart, and you're palpating your thyroid gland because he's looking for thyroid nodules. We now have about 30 people with papillary thyroid cancer, again because of the elevated growth hormone. He'll be listening to your chest and listening to your lungs, so of course, stethoscope. Then we also like to check you for abdominal ultrasounds for gallstones or kidney stones. And then if you have sleep apnea or snoring, we'll send you off for sleep studies. And then if you're having problems with your heart, whether he's listening to it, we'll send you for an ECG. We'll also send you for a cardiac echo. Then once everything is completed, we've probably already made the surgical consult. We meet with we have 2 neurosurgeons right now. We did have a third one who hopefully he's retired because he's got to be in his 80s by now. But they meet the tumor boards, they have those, so anybody high priority automatically goes to tumor boards while we're still doing the investigations, because we know, you can just tell, for most of the patients, as I said, they were 20 years probably before they've been actually diagnosed. So when we're looking at them, I also have a signs and symptoms sheet in here. Yeah, you know, it's the white one. The big light one? Yeah. I'll get that. So anybody that's been to my office, they've done the signs and symptoms sheet. It's 7 pages. It's somewhere in, here it is. So you come in, you check off all these things. Well, my new patient on Friday morning, she said, Lori, I only have a couple of these things checked off. And they mainly had to do with her prolactin. I said, that's a good thing. You're a newly diagnosed acromegalic, and you're new. It's very small. When we get your pituitary, your MRI done, that's a good thing. She said, what do you mean? I said, well, when I first started in this, most of my acromegalics were 50, 60, 70 years old. She's 33. She just got married. She said, can I have kids? Like, they keep telling me my prolactin level is going to be high. And I said, she had her blood work done a couple weeks ago, and then I did it again yesterday, or Friday. I said, it's 14.6. I said, your prolactin, though, it's still within normal range. And it's like, that's a big sigh of relief. Because, I mean, new woman, newly married, wants to have kids, what's it going to do? Because most of my patients, as you can go through different diseases here, they have, a lot of them have had like 5 or 6 miscarriages until they were actually diagnosed, before some of them never did actually have children at all. Okay, so there, I didn't include all of my signs and symptoms because we could be here forever. But as Mark mentioned, the headaches, the deepening of the voice, the sleeping, the prominent jaw, the swelling of the hands and feet. So. Can you pass your signs and symptoms thing around, or? Sure, sure. One of them, I actually got it published. This one. I actually got it published through Novartis, through Bev's help. Okay. So when we're doing your signs and symptoms, we're looking for all those core mobilities that Shireen and Sylvia and Ali talked about yesterday. The diabetes, the heart disease, the prolactinoma, the hypertension. Then we're checking for adrenal insufficiency, so you get to come and see me not only for the glucose tolerance test, but the insulin tolerance test. Cushing's, MEN1, osteoporosis. Then, let me think. So my first acromegaly patient that I tested, he's coming up to his 30-year mark in 2 weeks' time. So back then, I'm going to give you a little bit of a history lesson. It was a 2-day, 12-hour test. So Nick would come in on day 1, fasting, have to fast the entire time. And every hour I had to do measurements for growth hormone, glucose, and it was called somatostatin C back then. It's now called IGF-1. Then on day 2, he'd come in and we would test for growth hormone and glucose and somatostatin C, but then he would have, after the fasting blood work drawn, then he'd have his breakfast, still doing testing, then lunch, still do testing, then have dinner and still do testing. From then, that 2-day protocol turned to another 2-day protocol where you did your insulin tolerance test on day 1 for glucose and growth hormone, ACTH and cortisol and IGF-1. Part 2 of that day was your oral glucose tolerance test with 100 grams of glucose for glucose, growth hormone, and IGF-1. Then day 2, you came in for your luteinizing hormone releasing hormone for luteinizing hormone, follicle stimulating hormone, and growth hormone. And then the 4th part of that on day 2 was the thyroid releasing hormone test for glucose, for TSH, T3, T4, growth hormone, and IGF-1. So by the time, again, I got the nickname of Dracula. So then we switched from there to an oral glucose tolerance test with 100 grams of glucose. And then eventually, worldwide, we've gone to 75 grams of glucose. And their measurements are every 30 minutes. So there's 2 baselines and then a 30, 60, 90, and 120-minute samples. And as I mentioned, if you're now adrenal insufficient, which about 45% of our patients are, they have to come in for the lovely insulin tolerance test. Anybody here had an insulin tolerance test? Okay, I make you sweat. I induce a hypoglycemic reaction. And because of acromegaly disease, I have to give you even more insulin. Instead of 0.1 unit per kilo, I have to give you 0.2 units per kilo. Okay, I've already shown that. We've done that. So once all of those tests are done, for your baseline, then you see Dr. Izad in your clinic appointment, and then you'll see either Dr. Gentili or Dr. Zadeh for your neurosurgery appointment. And depending on what your condition is, Dr. Gentili and Dr. Zadeh prioritize you for your surgery. So we have had a set of identical twins, one with the acromegalic gene and one without. And because his sleep study was so bad, it was actually his respirologist that called us. He had had 100 episodes of apnea spells within his testing period. And most people might only have 2, maybe 3 times they wake up during their sleep studies, but he was waking up 100 times during that study. So obviously, I did his testing, I think, middle of December, and then before Christmas Eve, he was in having his surgery done. with a massive, massive, massive tumor. Many of our tumors are dual tumors, so it's secreting both growth hormone and it might be secreting prolactin. So when we're looking at drug medications, we have to make sure we've got all your blood work, and that's why you're getting a ton of blood work done. You're getting your growth hormone, you're getting your IGF-1, we're testing you for diabetes and other metabolic syndromes, we're testing all your pituitary hormones, anterior, not so much posterior to pituitary tumors, but and then all these medications, we start with both oral medications and injectable medications. So the injectable or the oral medications could be for your thyroid, could be cabergoline. Bromocriptine, we don't like to use it anymore. It's a really old, horrible drug for the proctinomas. So if you don't tolerate cabergoline, we might put you on Norpalak. Cortisone, replacement would be for Cortef, usually twice a day. Androgel or deletestrel for male hypogonadism, and estrogen or progesterone for females if you're amenorrheic. Vitamin B12 and vitamin D, again, we draw those levels every time that I see you in clinic. I had a number of patients report the numbness and tingling after one of their medications were given. And so I thought, okay, we have a huge practice. I'll just start drawing. Ran off to the boss and said, this is what I think it is. Do you agree with me or not? He said, yeah, go for it. So we started drawing B12 levels, because B12 is nerve conduction hormones. So we thought, okay, fine. So we started drawing B12 levels. Well, sure enough, these people with the numbness and tingling in their hands have vitamin D, vitamin B12 deficiency. And most patients, well, most Canadians, if you don't get enough sunlight or you don't drink your milk, you're probably vitamin D deficient. Well, again, acromegaly, we always check because, again, most of you are vitamin D deficient. Let's see. So, injectable medications. So as Mark said, he was one of the first patients, and probably would have been with either Edna and Alma back then, that started on the Sandostatin trial. Were we still at the Wellesley then? I think so. And then it just moved to Sinai? Yeah, okay. So I was using Sandostatin, the sub-Q form, in our hematology and our AIDS patients at the Wellesley because of the chemo-related diarrheas and the AIDS wasting diarrhea. And then Shireen did the initial clinical trial for the Sandostatin, which at that time when I had started, I closed the Wellesley in September of 2000, so then we moved. He'd already been over at Sinai, I think, since 96. So then I had to start learning how to give the injections. And I was getting massive phone calls from family physicians and their nurses saying, it's clotting, what can I do? So Mark showed you his pictures where he had the ampules that you had to draw up. So I thought, okay, fine. If one ampule isn't enough to dilute it so that we're not clotting, particularly since most of our patients are on 30 milligrams of Sandostatin, I would open up the second ampule and draw up some fluid, keep twirling it so that it's not clotting, and it worked. So I reported it to Shireen, reported it to the drug company, and in the States I discovered they only get one ampule for their Sandostatin back then. So every time I kept coming up with these things, I'd reported off to Bev and to Novartis and saying, I think really we need to use 2 ampules when you're mixing the 30 milligrams. 10s and 20s were fine, but the 30 milligram, because there's more molecule in there, you got to keep it moving. Too many people were complaining, and I would report every time somebody was having, from the family doctor, if they were having problems with the injections, and then if I had problems. And we actually ended up pulling one lot number because all of us were having problems so that they could actually test it. And the test worked fine, but so long as the product was fine, so long as we ended up adding that extra diluent to it, that we solved that problem. Then, so for that reason, that's why the Sandostatin now comes in a pre-filled 2.5 ml syringe, is so that you guys don't go through the problems that we had to go through back then. The second thing that we came along with was, when I left the Wellesley, we were already using safety needles. So it took a while, but eventually we got them switched over to safety needles in your package, because we were trying to prevent needle stick injuries, both for the nurses or the patients or their significant other who were giving the injection. Then we started the access program. We met with Novartis, and we had a large group in Ontario and Quebec, and that's where we started the access program. Their head office is in Quebec, and it's working really, really well. So we're glad. It's expanded all across Canada and into Britain and Europe, correct, Bev? Yeah, okay. The other injectable medication you might have is lanreotide. It's also called Somatuline. When we first started using it, the product was under Tersica. Then it became under EMD Serono, and then eventually it became under Ipsen. And again, we also encouraged them, we helped to get their access program started, because again, if I've got 600 people coming to see me for injections, I've got clinic 3 days a week, I've got injections, I've got endocrine testing, there's physically no way I can give 600 injections every month. So thanks to the access programs for everybody, that I give the first dose, and then you go out into the community and you arrange with the program so that you get your drugs at home. Then the next drug we started was with pegvisomant. We did the clinical trial for pegvisomant. So there were a number of patients, some of them are here, and I'll get Rada's assistance again for my lovely little things here. If you can pull those out, and the arthroscope. So not only do we do all the blood work, all the scanning, we have Shireen's arthroscope, which he measures your ring size. Just give me a finger for a sec.
You gotta move to the middle of the stage.
Okay. In order to get this on. No. Okay, hold your hand up. So it will actually give me a measurement, and each hand is going to be a different measurement, and depending on what your measurement is, I might be able to even tell you, are you right or left-handed, if I don't know. So this is Shireen's arthroscope, which he's picked up, I don't know, maybe 30 years ago, and I had to ask permission to borrow it today. Okay. And in the drug studies, we have all these different jeweler's ring sizes. So obviously, we're not going to have any acromegalics that are down here. And some of these are A to Z, and then I forget how many. This is Z up to 6. So a lot of my patients were either Z5 or Z6 for their ring sizes when you measure down to your joint. Can you see? Okay, and then this one is on millimeters. So again, they go all the way up to huge sizes. Yeah, 40.
15 to 40.
Yeah. So again, every time that you were coming in, I'd have to measure both sides, both hands, for your middle finger till your flanges. And then as you were progressing through the drug study, your swelling starts coming down, so the numbers we have to record on the data sheets. So for the patients who were like Z5 to Z6, we might get them down to a Z1 or 2. So it's still quite large. And again, it all has to do with that edema. So once your edema starts coming down, your weight starts coming down, your blood pressure starts coming down, you're not having the carpal tunnel syndromes. We've had patients who've had carpal tunnel surgeries by a neurosurgeon. It's like, did these surgeons not like look at your head and your hands and your face? Like, why are they only doing your wrists? Why didn't they do your pituitary surgery first? Then you wouldn't have had to have carpal tunnel surgery because your nerves wouldn't be entrapped and you wouldn't have all this extra fluid. So pegvisomant we did that clinical trial, just the booklets. So imaging, you'll have an MRI scan, you'll have your visual field testing, colonoscopy, because we're looking for colon polyps and colon cancer, your neck ultrasound, because we're looking for thyroid nodules, we're looking for papillary thyroid cancer. I said we've got 30 papillary thyroid cancer acromegaly patients. We have women with breast cancer now, the bone mineral density, because we're checking for your bone loss, and every time I do your blood work, you're getting your calcium, magnesium, and vitamin D levels done, and echo and 2 ECGs if you need to. Signifor we really don't use that much of, just because everybody that we did try, we used it for the our NET. We didn't get into the acromegaly study, but we used it for our NET study, and everybody became diabetic. We had one person who had slightly elevated glucose levels to start with. She ended up in the 50s, and we had another woman after 2 injections. She ended up in ICU with an IGF-1 glucose of 71. So we haven't really we've only used the Signifor for a couple of Cushing patients. Switch. Surgery. Okay, so we showed you the model. Your transperineal surgery is what we do now. You go up through both sides of your nose. You're usually in hospital about 2 or 3 days if everything's going all right. If you're having a leak, a CSF leak, then you're going to obviously be in hospital a little bit longer. But for most people, they're usually in hospital for 3 days. Radiotherapy, we have 2 radiation oncologists at Princess Margaret that we use. We try not to do radiotherapy anymore. It was something more that they used a lot of in the 70s before we had all these drugs available. So if there's a couple of people that have had radiotherapy, then it really doesn't have maximal effect until about 5 to 10 years post your radiation therapy. And that's when you become hypopituitary. So that's why when you see all those drug lists, the cortisone, the testosterone, the estrogen, the thyroid hormones, then you're all going to have total thyroid or total hormonal replacements. So post-op care, you're still going to have the same amount of blood work that you had, unfortunately, pre-op. You're going to have the same 75 milligram oral glucose tolerance test. We like to do it about 6 weeks post-op, so if you're having surgery, let me know so that I could get you booked into my already overbooked schedule. You're still going to have an MRI both in the surgery, in the operating room. Dr. Gentili will do an MRI, as well as post-operatively. If you need to, after you've done all your post-op blood work with me, then you'll see Dr. Izat, and he'll make the decision whether you need to resume medical therapy, either oral or the injectables. Because not everyone is, but as Mark said, if you have any residual tumor around the carotid arteries, around the optic nerves, then yes, you are going to go back onto your pre-op therapy. And I know Dr. Imran doesn't do it, but we pre-treat everyone with Sandostatin LAR pre-surgery. Usually 3, sometimes 4 injections, because it's going to shrink your tongue. It's going to shrink the swelling in your throat, so it's going to make intubation much, much easier. And if the pituitary, if there's any swelling in there, it will help to try and decrease that swelling, so it makes surgery easier transvaginally to get more of the tumor out. Okay. So then your visits are every 3 or 4, 6 or 12 months as you start progressing through. And then if something comes up in the meantime, just give Catherine a call and we'll book you in for an appointment if something else comes. Now, follow-up or pre-op appointments. We have a large patient population, anywhere between 5,000 and 6,000 active patients right now. So please keep all your appointments with the physician and myself. In my endocrine testing world, I have 75% of the patients that don't show for their appointments. I have one stretcher. So when I'm trying to get people in, I've got people booked for an appointment for 3 hours. I've got my injection people coming. I've got people coming from random blood work. I've got my sales reps coming. I've got people coming morning and afternoon for testing. So if you're even arriving a half an hour late, that just skews my whole day, because then the second person that's coming for testing, I can't get them started on time. Bring a buddy with you or a family member, because as Mark mentioned, memory can be a challenge for some people. It doesn't have to do with age. The ones that don't show up the most are the kids, transitioning from sick kids. My youngest acromegaly was diagnosed, he was 15. He's now 33. My youngest female was 18 at the Wellesley, and her mom was a nurse, and she picked it up. So that's how we got her in for testing. She's now married and has 2 teenage kids. A lot of our patients, particularly the women who hadn't been diagnosed in that 10 to 20 year, they were trying to have kids and have maybe 5, 6 miscarriages. Those that have had successful surgeries are now having kids without any problems whatsoever. So as I said, please bring a buddy to your appointments. And a complete list of all your medications. It includes your prescribed medications, your injectable medications, the list of them, your over-the-counter medications, so your Tylenol, your Advil, whatever, your vitamins, your minerals, your herbals, your naturopath, your homeopath, because we need to check, are you going to have drug interactions? Particularly if you're complaining of new signs and symptoms, or you've developed a new rash, have you had any allergies? So everything is electronic, so we keep, so every time you see somebody's supposed to be asking you, are you having new allergies? Because again, if you had a CT scan and you suddenly broke, or an MRI scan and you had the dye, and you've suddenly broken an interaction, we need to know about it. So I can get it documented in the computer, so when you go for your scans, either we have to switch the dye they give you, or pre-medicate you with the dye, or do an entirely different test. Because again, the CT or the MRI department doesn't want to find out they're going to have somebody going into anaphylaxis in the room. Know your team. Know who everybody is on that team, your endocrinologist, your nurse, because there's very few of us across the country. My girlfriend Lisa was supposed to be here from Halifax this weekend, but she's in a family emergency. Know your surgeon, know your pharmacy name, your pharmacist, and the phone and fax numbers. Because if we're in clinic, we're giving you, if you forget to take your prescription with you, we need to be able to get that prescription to you so that you can start it right away. And when you're coming to clinic appointments, wear comfortable clothes and shoes. Let me go back. Oh, no, it's okay. When you're coming for clinic appointments, wear comfortable clothes and shoes. Bring your medications with you if you have to take something during that day. Because if you're going for your blood work first, then you're having your clinic appointment, then we might need to send you for an x-ray because you've fractured your ankle or you twisted something, or we think you might have a deep vein thrombosis and we have to arrange for imaging to see if you've got blood clots. You could be here all day. And you want your appointments on time, so be on time or be a little bit early so that when we know if patient, because not everybody calls to cancel or reschedule, they just don't show up, which again puts us at a disadvantage because now all those people who didn't show all have to be rescheduled, whether it be for endocrine testing or for the visit with Dr. Izad. And many of our clinics, particularly at Princess Margaret, we're trying to get everybody, all our pituitary patients over to Toronto General. When you're going to the blood lab, you now actually get a time when you're going to the blood lab at Princess Margaret. They haven't started it yet at Toronto General, but again, that helps with staffing because we have no idea how many people per day are showing up in the blood lab. My office is in the blood lab at Toronto General. Some days we might have 1,700 patients show up, but we've only got 2 staff scheduled. Other times during the day, you might have 200 people show up all between 9:30 and 10, and then there'll be nobody at 2 to 4 o'clock in the afternoon, and then we'll get another big load at 4 o'clock or 4:30 as we're trying to close the lab at 5. So it's going to help to try and schedule people in. When you're coming to clinic, I know this happens, and unfortunately it happens a lot. Try and be pleasant. I'm trying to be tactful here. You'd be surprised at how many temper tantrums that we get saying, I've been here for 3 hours and I haven't been seen. Well, we can check to see when you checked into the blood lab, when you checked in for your scans, when you checked into the front desk. So you might have been 3 hours in the hospital, but you've been doing all these different tests before you get to us. And if you leave the unit and go off for a coffee or go to the bathroom or go wherever, and the doctor comes out to get you and he can't find you, he's gonna be a little antsy. So then they'll go on and call the next patient in. And then, of course, you'll come back and say, well, my appointment was at 3 o'clock. It's like, yeah, but you weren't here at 3 o'clock when the doctor came to get you. So they went on. We've got to keep the clinic moving. Yeah, Princess Margaret, we're only supposed to see 18 patients in our Monday and Friday clinics. We traditionally run 26 to 32. On our all-day Wednesday pituitary clinic, as we're supposed to probably see 36, we usually run anywhere up to 54 or 56. And then, as I said, if people don't call in to cancel, they just don't show, we're still waiting for you. So are you stuck in traffic? Are you stuck in the elevator? Are you in the bathroom? Or are you just not coming because you just don't feel like it that day? The other thing that puts us behind is we like it when you have questions. Try and pick the most important questions you have or send us an email beforehand so that we can have a look at them beforehand so we have the answers already ready for you when they get there. So if someone comes in and they've got 20 questions, Dr. Aza tries to answer everybody's questions. Or if you're coming to see me, because you're going to be with me for a captive audience for 3 hours, I try and answer all your questions. And then that just sort of puts us behind. Because a follow-up appointment is every 15 minutes they're booked. A new patient is 30 minutes. And notoriously, our new patients, because there's so much information we have to give you, you may actually be with us for an hour and a half. So again, that puts clinic that much further behind. At Princess Margaret, we started a pilot a couple of years ago called DART, the Distress Assessment Response Tool. And I know people, if they're particularly when they were going there, every time you'd come, you'd have to do it. Well, that's mandated by Cancer Care Ontario. There's nothing we can do about it. Acromegaly disease, it's a tumor. It's a benign tumor, but it's still a tumor, and it's still mandated by Cancer Care Ontario. So that's another reason why we try and move everybody over to Toronto General. But again, we don't know if they're going to start mandating us to do DART, and we have DART both in paper form and electronic form. The paper form is just 10 questions. The electronic form, I think it's 24 questions. But again, we can track it to see, are your signs and symptoms getting better with your treatment? The other thing we piloted, which both DART and the patient portal are now hospital-wide throughout all of UHN, so that's Toronto General, Princess Margaret, and Toronto Western. The patient portal is we give you a code number, you log on for your own account, so you get your own information. So your blood work results, as soon as they become available, goes off to you. Your MRI results, your CT scans, your ultrasounds, your doctor's dictated notes. Once it's completed, you get all that information. So sometimes I can draw patients' blood work, give them their injections, and as they're on the GO train or UP train or the TTC train, they've already got the results on their device, their laptop or their computer, whatever. And the other thing we had the hospital finally do was add in normal age-related values. So you can see it will come up either complete or abnormal. So even if it's 0.1 over or 0.1 under, it could be abnormal. But then the other thing we had them add in, took a couple years to convince them that they needed it, was to be able for the patients to trend your results. So if you trend say your IGF-1 and it says abnormal, well, click the trend button and it will give you all your past IGF-1s that we've drawn. And then it's like, are you in your normal range, what you normally are doing? So if your IGF is normally 300 and you're 301, no big deal. But if your IGF-1 is suddenly 691, then that is a problem. We need to know about it. Of course, our physicians have to review blood work every single day that they're in the hospital. And if I'm doing testing, I still review the same stuff for the testing that I've done for you. Your glucose tolerance test, your insulin tolerance test, your ACTH stimulation test, whatever. I'm still checking those results too, because the lab's calling me with all calling or paging me with all the abnormal results. So trend your results, because what's normal for you, don't freak out about it. If it's suddenly a big deal, then you're going to get a phone call from one of us in the office, either myself or one of our endocrine fellows. Okay, now we have access programs. And Rada's got books. So Lisa and I wrote somewhere, this one. Lisa and I and a group of nurses, we got together many years ago and wrote this. So it's been published, I think, 3 different times under different companies. And then we wrote, Lisa and I wrote this one. And these come in English and French. So ask your sales reps or ask your nurse if they have any of these books if you haven't seen them.
So you're the lady I need to talk to. We need to upgrade that with all the new support groups on that, please.
Yeah. Well, if we can get our support group up and running, then we'll add it to it. Then each of the drug companies, Dr. Izat and I work on all these different booklets. So again, over the years, they have all changed. Our Somavert book, our Somatuline book, as I said, my Acromegaly, that was from my worksheet. Ibsen has their own package, and then a number of our international European physicians. Dr. van der Lilly has been to speak to us, Dr. Negers has been to speak to us, and a couple of weeks ago, Dr. Stratsberg from Germany was with us. So we've had 2 from Holland and 1 from Germany speak to us. So they put out this book many, many years ago, which is no longer available, unfortunately. And that's it. Okay, so we have different websites, both for either if you want more information on your actual drugs that you're using, or you want auto trackers, if you want support groups. I've put a number of both Lisa's group, Deanna's group, and my email are up there. And in the backs of these books, we've included various websites that Dr. Izat has approved, because we're not into blogs. They don't give medical scientific knowledge. It has to be medically and scientifically approved before we'll put an information in there, as well as the different access programs to get a hold of your clinical nurse specialist from the access programs are there. And just to close, I just want to make one point. If we don't know about it, we can't help you solve it. So just remember, we cannot help you if we do not know the problem. Don't be afraid. We're not going to bite you. We're not trying to scare you. We're trying to give you information and as clear and concise as we can be and as accurate as possible. And we're here to help you. Okay? And our lovely nightlife in Toronto.
I want that pituitary thing. please, when you retire?
No, because I'm still trying to get a new one, because mine is so old and so broken. Shireen has the perfect one in his office, and he has the thyroid one, and none of us have able to get, there's a bum one, but none of us have been able to get that one.
Here you go.
Thank you. Yes.
What I do is I kind of keep a record of what's going on from my last appointment to my next appointment. And about a week before, I email that list to Dr. Izak.
Yeah.
It is there.
Yeah, which is great, because whether you've emailed it to me and then I print it off and then we put it, because all this stuff goes into your chart. And because, as I said, we have so many patients, and they've actually taken away our file room, and they've taken away 2 of my filing cabinets, we're now starting to scan all the documents so they actually become part of your electronic medical records so that they can still see. The other thing Dr. Asa talked about yesterday is about pathology was, if you're having your surgery done in Timbuktu, which I don't recommend, you're best to go to a center of excellence. That's why a lot of patients end up having multiple surgeries. Because some of them, a lot of our patients we've had, like IGF or growth hormones after their surgery of 29. Well, it should be like 0 to 0.4. And so we'll order in path reviews from Timmins or Ottawa or Windsor or wherever you've had your surgery, and then Dr. Asa and her team will do an actual path review. They'll obtain those samples from that outside hospital to have them analyzed and test them for more of the staining, because as she said yesterday, some of our samples, she's done 20 different stains on it to get an accurate diagnosis. Particularly not only for the pituitary patients, but the NET patients, that they can have that many different positive stainings. So when we're doing medications, certain medications work for certain things. She talked about the densely granulated and the sparsely granulated systems, which we don't really look at now, but years ago when we were looking at medication therapies, why they either worked or they failed to work, it was because it wasn't, you needed more drugs. Okay?